get started to get through the logistics. For those who don't know me, my name is Diana Chang Blanc. I work for WHO in the Department of Immunization, Vaccines, and Biologicals. And I'm the team lead for program strengthening and one of the focal points on the COVID-19 vaccine partnership. So good morning, good afternoon, good evening to those who are here. So pleased to have you join us in your busy schedules. So let's go to the next slide, please. So today's session is our second session of this series on best practices on COVID-19 vaccination strategies with integrated immunization services. Next. And it's part of what we're calling the Learning Collective that's hosted by the COVID-19 Vaccine Partnership, primarily focused at supporting the 34 countries of concerted support so that countries can directly connect with each other, share stories, learn from the different practices each of the countries have been challenged with these past couple of years. Next. So it is a 6-session series. We are running one series a month. The last session was at the end of May on the best practices and strategies for identifying vaccinating high priority risk groups. And we were honored to have the Ministry of Health of Sierra Leone and Burkina Faso present their experiences. And we're very delighted today to have our speakers on the best practices of COVID-19 vaccination strategies with integrated immunization services. We will have Dr. Faraz Al-Massawi, who is the National Immunization Program Officer for Iraq, and as well Mr. Johannes Lakiu, who is the EPI Manager and also the COVID-19 Vaccination Coordinator for Ethiopia. And we have some interesting presentations lined up today, so really looking forward to hearing those. Over the next 4 sessions, we have tentatively identified these thematic areas to be covered. So anybody on the call who works in a country or works with a government that might have an interesting story to tell, please feel free to reach out. Really would be delighted to spotlight any of those practices at one of the upcoming sessions. Next. So with respect to what will happen today, we'll move into housekeeping, which Santosh Gurung will cover. We'll cover each of the presentations with a short Q&A afterwards, where I hope other countries can feel free to bring in their experiences or questions, and then do a wrap up and a closing. And what we have found that works most efficiently is to please feel free to type your questions in the chat or any reflections in the chat. And as we roll along, I will ask those, if you can, to also just type in your name and your country and role where you're listening in from. It gives everybody a sense of who's on the call. So with that, I'll hand it over to Santosh to run over housekeeping. Over.
Diana, thank you very much, and welcome everybody. I'll just walk you through the housekeeping slides, just a few slides to get you oriented with the session. So for this webinar, we have the translations that's available in French. So if you can just see the button, the interpretation button on your taskbar, you can just go there and choose the language that you prefer to listen to. We have English and then we have French. Next slide, please. We also have the live transcription in English. So if you choose to kind of get a full view of the transcript, you can click the live transcript button and you can show the subtitles to kind of view the transcript as we move along with the presentation. Next one, please. So we have the chat, please feel free to put your questions in the chat, but we will also, after each presenter is kind of made his presentation, we will pause for a few minutes to allow if any participants have any question to raise their hand and come in and ask the question. So yeah, we have the options of the chat to put in your questions, but also raise your hand to come up with a question if you have any. Next one, please. The session is being recorded and your attendance is consent to be recorded. The recordings, the PowerPoint, and all the resources will be available in the website in the Technic 21, which I will give the details to the link towards the end of the session. A certificate of attendance will be available through the University of New Mexico via the link in the chat at the end of the session. And I will also discuss about the updating the certificate in the end of the session. Next one, please. And for the data use, Project Echo, it collects registration, participation, question and answers, chat comments, and all the poll responses for some Echo programs. So your personally identified data will be shared with the project funder, and this data may be used for reports, maps, communications, and some sort of quality assurances, evaluation, and research to inform new initiatives. Next, please. Yeah, just to get, before we move, we dive into the presentations, we have 3 poll questions just to kind of get a feel in terms of what's the level of participation, where you're joining from, and what are the thematic areas that you're kind of interested in the upcoming sessions. Can you go to the next slide, please? So this is the first question. If you can all take part in this poll just kind of which organization do you represent? Are you from the Ministry of Health, from any other ministries of the government, from the UNICEF or the WHO regional office or the country office? If you're from Gavi or any multilateral donors, please fill in the details. And the link to this poll is in the chat. Please fill in the questions, and we will wait for the answers. Let's give it a few minutes. Can we show the responses to this question? Yes, so we have the participation from the UNICEF and WHO country office, from the regional office, and also from NGOs, as we're seeing on the screen. For the next question, just to kind of get a feel of which region are you based in, can we answer this question? If you, which region are you based in? Is it the Africa? Is it from Asia, Southeast Asia, from the Caribbean or the South American region, or from Europe, Middle East, North America, or from the Pacific area? If you could answer this question. Can we have the responses to this? Can we have the responses to this? The answer to which region are you based in? Can we move to the next slide, please? The last question for the introduction poll in terms of what thematic areas or topics related to the COVID-19 vaccination would you like to discuss in the next collective session? If it is on regulatory preparedness, planning coordination and service delivery, costing and funding, on supply chain and waste management, human resources and training, demand generation and RCC, on vaccine safety, monitoring and evaluation, or COVID-19 surveillance. So based on your responses, we will try and tailor the themes for the upcoming sessions based on these responses. Can we have the responses to this answer? Next slide, please.
Great. Thank you, Santosh. So we'll move into the first presentation from Dr. Faraz Al-Masawi. Just to remind everybody gently to keep their microphones off. When we get to the question and answer session, you will be able to turn your microphone on and off should you like to ask a question, and encourage everybody to as well put in the chat any reflections or questions you have along the way. So on that note, I kindly invite Dr. Faraz to open up his camera and give his presentation. Thank you so much.
Thank you so much. Good morning, good afternoon, good evening for all the attendees. This is Faraz Jabbar Al-Musawi, a public health directorate. I'm working in Iraq and expand my career in EBI. I was a provincial EBI manager for 14 years, and now since 2019 I am in charge of national EBI program in Iraqi MOH. I will present our experience with COVID-19 and integration activities as stated or called intensification of integrated immunization service. Next, please. This is an overview about our presentation. We will present some data and information about EBI and achievement, then COVID-19 pandemic and its impact on routine immunization, and the 3IS, which is the intensification of integrated immunization services, and the future plan for EBI. Next, please. This is an overview about Iraq. The total population, more than 42 million, distributed in 19 Directorate of Health and 155 health districts, and there is more than 2.7 thousand of primary healthcare center. Actually, 61% of them providing immunization services to serve 6 million of under 5 children and more than 1 million of annual surviving infants. Next. This is our immunization schedule, and since launching in 1985, we are succeeded to introduce all the antigen stated and recommended by WHO. Next. Actually, the program providing these doses as in a number of doses as recommended by the position paper of WHO. Next, please. Regarding the EBI achievement, next. Actually, in Iraq, there is so many tragic event and major event, and all of these all these events affecting all the programs in Iraq, especially the health program and the immunization system during all these tragic events succeed to providing their services for their target group. Next, please. Also, there is an built-in challenges. This next. There is a built-in challenge which is consistency in various aspects such as effectiveness and safety in our communities, also hard to reach area such as desert, marshes, remote area, and especially there is a security compromised areas till now, and community awareness and rumors and infodemics of rumors or rapid distribution of these rumors in our communities. Also regarding wastage concern and financial issues, and this will all these issues raising the vulnerabilities for resurgence of vaccine preventable disease. Next. This is one of the achievement of immunization program. Next, please. Since launching of EBI program, we are achieved the polio-free status in 2000s, and actually next, please. Actually, after ISIS invasion or during ISIS invasion, we are reporting 2 cases of polio. Next. And also, as a result of launching of EBI, we are controlling the immunization, the measles cases in Iraq, and right now we are facing a cyclic trend or epidemics of next, please, of polio since actually from 4 to 5 years we are facing such epidemic. Next, please. And also the EBI program, as stated by WHO UNICEF estimate of national immunization coverage, is one of the, or actually the third country that increasing coverage of DBT containing vaccines since during 5 years, from 2015 to 2019. Next, please. Iraq achieving about 16% improvement in coverage rate. Next. Actually, we doing a lot during 2019 to strengthen immunization program, and this is only the most important things. We are saving more than $78 million for procuring the vaccine, just by switching from hexavalent to pentavalent vaccine. Also doing a lot for the bottleneck analysis, and after that we're making an action plan, and we strengthening our program by establishment of CMIBs, immunization policy and strategy, also vaccinator field guide, EVN 2, and doing EVN 2 as a first country in the world conducting such exercise using this tool. And after that, we doing the comprehensive or continuous improvement plan, also reforming the National Technical Advisory Group to meet WHO standards, and also building a capacity of our healthcare provider at the different level, especially at the service point level. Next, please. Next. We are focusing about 3 objectives, which is quality vaccination, equitable services, and effective coverage when doing every activities in the immunization program. Next, please. In Iraq, the EBI program, as ordered by Minister of Health, take the lead of, with the same personnel, with the same structure, take the lead of response to COVID-19. Next. Iraq in the MENA region, which is the second country in number of cases and the 4th in the number of deaths. Next, please. And we are doing a lot for deploying the COVID-19 vaccine, and we are reaching 26% of total population with the first dose, and 18%, more than 80% with 2 doses of vaccine. Next. And actually, we are experiencing a marked decrease in the uptake of the vaccine since the beginning of 2022. Next, please. Impact of COVID-19 on immunization program. I summarize this in these points, but actually so many things impacted by COVID-19 in our program. The most important thing is the mobilization of the staff and funding from immunization program toward COVID-19 response. The care for that impacted the families to access the immunization services. The drop down in coverage rate, and also there is a risk of vaccine preventable disease resurgence. Next, please. In the next slide, I will present the fluctuation of vaccination during COVID-19. And as you see, this is the cases of COVID-19 under the wave during 2020 and 2022. Next, and this is the number of healthcare workers infected with COVID-19 with each wave. And in the green, this is the target state as stated by CMYB. Next, please. And as you see, this is the OBB1 in the blue and the OBB3 coverage rate when we are starting in 2020. We are in line with the target that stated by CMYB. Next. After first confirmed cases, and next please, and the implementing of the careful, there is a marked decrease in the coverage rate. Next please. Next. And next, and after that, we doing the rapid assessment and to know next, to know our situation and exactly about the continuation of fixed activities and the staff involvement in the COVID-19 response, whether fully or partially. Next. And we are doing a strategic response plan, take so many area and component to be addressed before any response to the decrease in the coverage rate and the fear of appearance of any vaccine preventable disease. Next. 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 After that, we're doing the mid-year review, and we are, as you see, there is a marked deviation from what we are planned to do in 2020. So next, we are started to implement next. Our response plan from August, and next please, when we are implement these activities, actually with our partner from WHO, UNICEF, and IFNET at that time, we are doing a lot and start to improve our immunization coverage. Next, and during that time, we also work with for other side to engage or joining COVAX and making a contract with other supplier for COVID-19 vaccine. So we are working at the same time for two directions with the same healthcare workers or the same human resources. Next. And also, according to the risk assessment tool conducted with WHO and UNICEF, we are conducting a subnational campaign using bivalent OBB. Next, that included 46 of our district. Next, and next, and during with the beginning of 2022, we are starting to to launching novel OBB and starting the training material, initiation or development of training material, and procuring all the logistics, especially for ultra low temperature freezers. Next, and when we are starting the training, there is a marked decrease, especially with the Delta wave, marked decrease in the coverage rate. Next, please. We are start to training at that time and succeed to train more than 9,000 participants, and they will be eligible to deliver the COVID-19 vaccine. Next, and we are starting the first dose of COVID-19 vaccine at 1st of March. Next. And at that time, we are facing also the drop down in the coverage rate. Next, and with the starting of the Omicron wave, we are making an expansion of the point of use of COVID-19 vaccine. And at that time, most of our healthcare providers are engaged in COVID-19 response. Next, so there is an obvious drop down in COVID-19. Actually, there is multifactorial about this drop down, but mostly about the overwhelming of the system and the healthcare provider. Next, please. Next. Next. After that, there is a fluctuation of COVID-19. Of the routine immunization. Next, and next, at the end of the 2021, doing COVID-19 mass vaccination campaign with the WHO. Next, and succeed to reach to deliver more than 400,000 doses of vaccine. Next, please. Next. And during COVID-19, doing a lot regarding RCCE with WHO and UNICEF and reaching our communities and using different channels for delivering the right message at the right time. Next, please. Also, there is so many measures conducted with our partner to advocating national and sub-national level to intensifying during COVID-19 to intensifying immunization services, allocated adequate budget for immunization program, and ensuring sufficient human resources and equipping healthcare provider with the PPEs and undertaking innovative and contextual social mobilization approach to regaining community trust in the health system. Next. The positive point, or the good point, there is so many partners at that time to willing to support COVID-19 vaccine. Next, and actually the threats of COVID-19, reversing all these threats to opportunity by using all the capacities, experience, and human resources, and any other resources of COVID-19 to make it as ethical, used as ethical to improve routine immunization. As you know, we are markedly impacted the routine immunization coverage. Next. So from that discussion, starting the idea of intensification of integrated immunization service. Next. The objective of 3IS activities was acceleration of control of COVID-19 and reduce the probability of vaccine preventable disease resurgence, and also improving COVID-19 vaccine uptake and bridging the vaccination coverage rate gaps and reaching the zero-dose children, and also availing community awareness about risk of COVID-19 and routine immunization, and strengthening the bilateral ties between health system and community. As you know, during the 2 years of COVID-19 pandemic, we are lose the contact with the community. So we need to reinforce and re-engage the community with our health system. Next, please. Next. I need to preserve time. Next, please. Also, there is so many activities done for monitoring and supervision at the different level, at the central and at DOH level and the district level. Next, please. And this will next, please. Next. Next, please. During this these activities, we are delivering on monthly basis about 500,000 of doses, and actually most of them are routine immunization, routine vaccines, more than the COVID-19 vaccine. Next, please. On the average administrated doses per session, actually we are conducting on mean more than 7,000 sessions per month. Next, and next, please. Next. The total number of doses per session, about 70 dose. Next, please. This will show the next. This will show the percent of COVID-19 vaccine administered doses through 3 IS from total administered using all strategies, and this is obviously about 20 to 22% in each month. The impact of 3IS in coverage rate. Next. And also regarding routine immunization, also the sharing of 3IS in coverage rate is obviously, and especially in the Benta 3 and MMR 1. Next, please. Next. And actually, when this is the comparison between 2021 and 2022, as you see, there is a marked increase in coverage rate when using 3IS in 2022. Next. And this represents the Q1 coverage rate comparing to the year before, which was high coverage on all the quarter of the previous year. Next. And this present the since for 2 months we don't have such high coverage rate of Benta 3 in Iraq. Next, please. Future plan for EBI in Iraq. Next. We will emphasize on accountability at all levels of the government structure, advocate for improvement of program, budget allocation, which is the main constraint in Iraq, and also implementation monitoring of CMYB and evidence-based planning process at the national and sub-national level, and will invest more in digitalization and streamlining of vaccine procurement. Next. And also tracking of unvaccinated children, especially zero dose or chronically zero dose children, and also improve routine immunization through a communication plan and be responsive for control any outbreak, any outbreak of vaccine preventable disease, And we work on routinized COVID-19 vaccination to routine immunization, and working a lot with BERI and also with 3IS, and in this in integration with other health program and activities. I thank you, and sorry for being so fast in delivering this material. Next, please. Thank you so much, and I am ready if there is any inquiries or a question. Thank you.
Thank you so much, Dr. Faras, for doing an excellent, very thorough presentation and doing really superb time management as well. So we have about 10 minutes for Q&A. So please feel free. We have to raise your hand. We have a small group today, which is great. And if you have any questions, please put them in the chat. I do have a question from Anshu Kumar about whether there were any issues on AFIs during COVID-19 vaccination. So why don't you hold that thought, Dr. Faras, because I see Dr. Dafrosas also raised her hand. So why don't I invite her to ask her question, and then you can take both questions. Go ahead, Dafrosas. You should be able to unmic.
Thank you, Dr. Faris, for the presentation. My question is on the delivery strategy for COVID and routine. As I observed that he pointed out the routine also coverage increased during COVID. Were the team delivering COVID vaccination at the same delivering routine immunization, and how did they plan the implementation while a routine going on? And as he has pointed out, he wants to routinize COVID vaccination. How is it provided now compared to what he's planning to do later?
Thank you so much. Actually, if I am talking about 3IS, we are using an outreach services and using the micro planning, actually bottom up micro plan, and focusing on the risk area, and especially the area with a high default rate from routine immunization and for COVID-19, especially the remote area. In each team consists of 6 personnel, 2 for routine and 2 for COVID-19, and 2 clerks, 1 for routine and 1 for COVID-19, and also 1 health promoter, which is a cornerstone for succeeded this activities, because they deliver a very helpful informations and responding to the inquiries from the communities when we are at the community at the site of conducting the outreach session. So from that area, and especially during 2 years we are away from our communities because there is an access problem in remote area, we are improving our coverage with routine immunization and increasing the COVID-19 uptake for the eligible personnel of that area. If you have any.
Yes, I think there was a question about whether you had AFIs during the outreach.
Any issue?
Yeah, any adverse events following COVID-19 vaccination?
Actually, we have a pharmacovigilance, and they reported any adverse event following immunizations during deployment plan, and I don't have any report of severe adverse event during implementing our activities.
Great. Terotras?
Yes, thank you. My name is Tedros from MENARO, UNICEF. I really appreciate the presentation and your best experience, which will help for other countries in our region. It's very informative. Thank you so much for that. I have some copies of questions just for the sake of clarification and to get some more information. The first one is when we see the COVID vaccination coverage, as to my observation, in couples of months back, the progress is not much, fast. I mean, still it's around 23%. Do you think that through this integration, the result of what we observe in the routine immunization is the same results observed in the COVID vaccination coverage when you compare the two, the childhood immunization versus the COVID vaccination. The other point related with expiring dose of vaccines, is there any effect which you observed through this integration? Any experience if you have? The other point, if somebody asked you just how can take your experience and want to implement in some specific area, from which point you advise, from where that person or country should start, for example. What I mean is there are different components when you see the COVID vaccination versus child immunization. There are differences in terms of target groups, in terms of space, time. So which contact points were effective or feasible to implement the integration strategy? Finally, sorry, when you put the vision or the next plan, you put PIRI as one component of the 3Is strategy. I'm not sure how much is the difference between the 3I versus the PIRI strategies. Both is intensification approach. So I don't know, there are some differences with these intensification strategies. Over, thank you so much.
Great. Thank you, Tedros. So there were several questions in there. I will see if I can capture, and if we run out of time, because we have just about 2 minutes left, we can ask the Dr. Faras to type the answer maybe in the chat. So I think the first question was basically on the integration. The routine immunization was clearly got a boost. Did you see the same boost on the COVID-19 vaccination side because of the integration? The second was, did you have any experience with expired doses of vaccine? And I'm assuming that's specific to COVID-19 vaccine. The third is really your wisdom. What is your wisdom now that you have this experience for integration? What would be the tip? We have several countries on the call, several UNICEF people on the call. What is your tips around integration? And then the last is the issue around peries versus integrated services, but I think that we might have to leave you to write that in the chat. I'll type the question or ask Tedros to type the question as we don't have a lot more time. So with that, I'll hand it back to you, Dr. Faras.
Thank you so much. Regarding the improvement of routine immunization versus COVID-19 during 3IS, I know we are doing a lot with routine immunization and improving a lot with routine immunization more than the COVID-19, but actually this comes with the global decreasing of the utilization and uptake of the COVID-19, and Iraq is one country in the world. Using the health promoter, we convince many eligible persons to take the vaccine, but for routine immunization, I think the families, the parents, they have willing to vaccinate their children more than other eligible to take the COVID-19 vaccine. Regarding the experience for the expired dose, exactly, Dina, this is regarding COVID-19. As you know, there is a 6 month and for Pfizer vaccines and all of the other vaccines, and they come to Iraq with a short life, less than 90 days, sometimes 100 days, but most of them less than 90 days. And there is an approval for extension, but our legislation prohibit us from using any vaccine after or beyond the expired, the label that stated the expired date. So we are facing a wastage concern and wastage doses in our countries. Regarding Berry versus 3IS, I think there is some differences between them, because 3IS is doing according to the micro plan and no time limits. As you know, the 3IS may be doing in 3 rounds and for 10 days, for example, and using the 2 or 3 according to the microplan antigens, but right now in 3IS we're using all the vaccines except the BCG vaccine for routine immunization, I mean. So there is some differences between them. Regarding the tips for, I think the integration is the solution, and especially when using the scientific tools, and when working together with WHO and UNICEF and MOH, exactly under the leadership of MOH, we're reaching a lot and reaching all our targets, especially for the 0-dose children. This idea is exactly coming from our integration and delivering so many ideas and discussion, and after that we are stated there should be an integrated services to improve our situation, and exactly this is the reversing of threats of COVID-19 to opportunity to improve our immunization system. Thank you, over.
Great, thank you, Dr. Faras. So on that note, we're going to have to shift now to another country, Ethiopia, and I will hand it off to Mr. Johannes Rakiu. Thank you.
Thank you very much.
Mr. Laque, can you see the screen?
Hello,
Hello? We
Can
hear
you hear-
you. Yes, we hear you now.
thank you very much. I think this is Johannes from Ministry of Health, Ethiopia. I'm the API manager as well as COVID vaccine program coordinator as well. So I will present you the best practices that we have as a country on COVID-19 vaccination, as well as some of the integrations that the country recently tried to integrate with the routine immunization. It's not actually the overall performance is not assessed with the integration, but we have tried to integrate the routine immunization with the COVID-19 vaccine rollout. So next slide, please. So as you know, Ethiopia is a very big country in Africa, which is the second populous region. We have more than 100 million people. Ethiopia is geographically located in East Africa, and we have around 13 subnationals, including 2 city administration. And there are, within these subnationals, we have more than 115 zonal clusters. Within that, we have almost more than 1,000 districts, which is equivalent to districts. So where the majority of the community or the peoples are living in very rural areas, around 83%. Ethiopia will also cover more than 1 million square kilometers as well, and the bordering with different countries, more than 5 countries. Next slide. So in terms of health infrastructure, we have more than 395 hospitals, more than 3,700 health centers, and we have around 18,000 health posts which are providing the vaccination, both the routine as well as the COVID right now. And we have also national and regional reference laboratories for laboratory diagnostics for VPD as well. And in terms of logistics, we have one central logistics centers which is owned by government, and that central logistics center have 20 satellite distribution hubs in the country. So those 20 satellite distribution hubs distributed all the vaccine and other logistics to the health facility and to the districts. So basically, immunization service has been given in more than 21,000 of health facilities are providing routine immunization as well. Next slide. To show you, the immunization landscape in our country, it was launched in 1980s according to the Gregorian calendar. So since then, lots of new vaccine has been introduced. Basically, majority of them were introduced since launching of the Gavi into this world. So Gavi have supported a lot of new vaccine introduction in our country since 2007. We introduced pentavalent, and in 2011 we introduced PCV, then Rota, IPV, transition of trivalent OPV to bivalent has been made in 2016. HPV single cohort age group was introduced in 2018. MCV2 measles containing vaccine introduced in 2019. In 2020 we have made TT to TD switch, as well as PCV10 to PCV13 switch. So recently, we are working in a hepatitis first dose pilot. Again, we are working in a preparation to introduce IPV2 second dose. As you know, in 2021, we have introduced the COVID-19 vaccine for emergency use to prevent the pandemic. Next slide. This is, to show you the some of the history of the COVID-19 disease and the introduction of vaccines. Ethiopia reported the first case in 13th March 2020. After 1 year, as you see in the graph, in 13th March 2021, we introduced the COVID-19 vaccination after 1 year's gap. So since then, we have providing millions of doses of COVID-19 vaccine. Next slide. So in terms of coordination, the COVID-19 vaccination rollout was coordinated by the minister, basically, and under the minister, there are different working groups. We have a COVAX secretary. Then we'll have 5 different working groups. The one we work on supply and logistics. We have different stakeholders on this as well, like UNICEF, CHAI, recently WFP and others also joined this working group. And we have a planning, MND, and the service delivery wing as well, which is coordinated by the ministry, and where WHO and other partners has been participating. WHO is basically the secretary for this working group. Communication and demand generation is one of the critical tasks that is also coordinated by the ministry, which is led by the ministry, and UNICEF is basically the secretary for this working group. And we have another working group. We call it Vaccine Safety, Licensure, and the Pharmacovigilance Wing, which is led by Ethiopian Food and Drug Authority, and where WHO is a member of it and a secretary. The last working group is Infection Prevention, Surveillance, Research and Development Wing, which is led by one of the institute by the ministry. We call it Ethiopian Public Health Institute. So this institute, with the support of different stakeholders like WHO and others, coordinating the infection prevention, surveillance, and the research development activities of the COVID overall response activity. Within this, we have different advisory group, independent advisory group. We have Ethiopian NITAG, and as well as clinical advisory team. We're also supporting this COVID-19 rollout. Basically, the clinical advisory teams have supported the ministry in terms of target prioritization at the initial phase of the COVID-19 rollout. Next slide. So when you come to the service delivery of this COVID-19 vaccine, actually we adapted from the routine or the existing traditional vaccine delivery modality. So we have a static vaccination sites, outreach, and the campaigns mode also used, especially schools where the major vaccination sites. Mobile health and nutrition team also deployed, especially in IDPs and the refugee areas. And again, in large IDPs and the refugee sites, we have a temporary fixed site for vaccination. So these 4 modalities of service delivery has been utilized by the ministry to vaccinate our people. Next slide. So as a country, we had we started in, as I mentioned, in March 2021. Since March 21 to December 2021, the vaccination program has been given in a fixed sites, basically in the health facilities. During that time, the vaccination uptake was very low, and the ministry tried to strategize its modality of service delivery and launched a round 1 COVID-19 campaign. So in December 2021, the ministry has conducted round 1 campaign by considering around it was planned to vaccinate around 5.5 million people at one time within 2 weeks. So that campaign was successful, and it was conducted in December 2021, and we managed to vaccinate 5.5 million people within a short period of time within the round one campaign. Taking the lessons of the rollout as well as the round one campaign, the ministry with the stakeholders and the partners had also planned to conduct a round two campaign in February 2022 to vaccinate more than 20 million people within 2 weeks. So with that campaign in February 2022, we conducted a huge campaign. So it was successful, and a lots of lessons also learned from that campaign, and we managed to do that as well. So taking the lessons of the rollout, which is from March to December 2021, and taking the lessons of round one and the round two campaigns, the ministry was planned to take a third round campaign of COVID. So with the objective of building population immunity, increase the vaccine coverage, and reduce the impacts of COVID-19 pandemic on different sectors like economy and social and the political and psychology as well. So the third round campaign was framed with these three basic objectives. So it was started in June 2nd as a nation. So it was started in June 9 as a nation, and with that we plan to vaccinate around 25 million doses within 2 weeks. So far it was very successful, and most of subnationals has been finalizing their campaign, and a lot of improvement has been observed. Next slide. So to do this campaign in a different modality, the coordination from the national to the subnational level was monitored by different platforms. We prepared a readiness assessment tool and deployed it to subnationals to monitor their readiness as well. And the different coordination platforms like WhatsApp, Telegram groups, and the virtual platform has been used to coordinate all the activities that has been takes place in all areas. So the coordination is one of the very critical tasks. Unless you have a very strong coordination mechanism, it will be very difficult for the nation to vaccinate 25 million doses within 2 weeks. So it was coordinated by the top leadership as well. All the regional subnational health bureau heads also coordinating these tasks, including the political leaders as well. So most of the people are engaged in this campaign, especially the leadership. Next slide. EPI task force that encompasses all the stakeholders, all the partners, and the subnationals has been also convened. On that meeting, a lot of resources were mobilized for this campaign. So even partners have deployed a lot of supervisory team to the subnationals to monitor and support the campaign. And and we also prepared analysis dashboard that shows the performance of each subnationals to take an immediate action based on their performance, and to have an informed decision. Next slide. So availing the vaccine is not the only task for the COVID. So demand generation will be one of the critical tasks that is required for the campaign to be successful. So with the recent challenges that the global community facing on the vaccine hesitancy and the refusal, we also suffered with this challenge in the previous two campaigns. So for this round as well, we have planned a demand generation activities with different modalities by segmenting even the audiences as well. So the campaign was launched by different levels, by national, subnational levels. Community discussion were also made at different levels. advocacy meetings also conducted at different level. Even the religious leaders, as you can see in the pictures, has been participating in the launching events as well. They have been used in a panel discussions. So a lot of communication activities were conducted. Social media campaigns, including top officials, has been supporting this mobilization activity. Short TV and radio spot messages also used to mobilize the community at large. Next slide. Media peoples also trained on the COVID vaccine, about the campaign, about the importance, about the risks that we have as a nation. So media peoples oriented, and they have been supporting the campaigns and as well as the rollout. Different peoples like, peoples with a disability and their associations were also trained, and they also mobilized their members for the vaccinations. Panel discussion, town criers, and the community mobilizers largely utilized for the first campaign as well for the second, even for the third campaign. They have been a part of mobilization. Next slide. This is almost the same, and the SMS text is also sent to all communities who have a mobile cell phone. So almost many people have received our message from through different text SMS messages. Next slide. The other issue is one of the critical tasks for the campaign is logistics. So distributing 25 million doses, at the same time distributing logistics like syringes, safety boxes, printing material like cards, registers, tally sheet, reporting format. It is not an easy task for the country like Ethiopia to distribute it for within a short period of time. So we prepared the micro plan, and we validated with the subnationals, and we shared for our agencies, the one who distribute this logistics, and we mobilized partners to support this distribution. So within 10 days, we managed to distribute all this logistics to the lowest level of the health system, to the health centers and the health posts. So in this modality, we used a lot of different transportation means. Next slide. As you can see in this picture, so we have used freights to distribute logistics, where we have a challenge to distribute logistics due to security blockage. We used vehicles called vans, we used motorbikes, we used even camels to distribute logistics in all corners of the country. So as I mentioned, it is not an easy task for the ministry to do the distribution of this huge logistics at one time. So thanks to our partners and our committed staffs, we managed to distribute this logistics. In history, we haven't such an experience to distribute such big logistics in one time. So we are learning through the process as well, and we are testing our systems, how much we can handle to distribute such a huge amounts of logistics in one time. Next slide. So as a nation, we received more than almost 67 million doses of different types of vaccine. From this, we have distributed 57.8 million doses to the subnational and to the health facilities for utilizing to vaccinate our people. And we have at the national level 8.8 million stock on hand of different vaccines. So we have received disease vaccines from COVAX majorly. Almost 52 million doses has been coming from COVAX. From bilateral government to government donation, we have received 13.7 million doses from African CDC and African CDC procurement through AVAT. Also, we received almost 1 million doses of vaccines. So these are the vaccine doses that we received. We have so far we received J&J, Sinopharm, AstraZeneca, and the Pfizer vaccine as a mission. Next slide. So in terms of service delivery, we, as I mentioned, we used campaigns. So team were composed, team also deployed for this, and at least 5 individuals were deployed for the campaign, because one will provide the vaccine, the other will provide will register, the other will mobilize, the other will also mix the vaccine or dilute the vaccine. So we have used also ODK for monitoring and supervisions, and operational budgets also used for incentives for outreach service as well. Next slide. So as you can see on the map, this is the ODK report that we received from the field, real-time data for action. And for this, I think almost all the teams has been supervised. The area that shows, doesn't have any spots of ODK, there are connectivity issues due to different reasons. So almost all the teams has been supervised through ODK application to take real-time data and immediate actions. Intensive campaign support through different stakeholders has been conducted, and the community mobilization during intra-campaigns also conducted. Next slide. So with the third round campaign, since the start of June 9, our plan was to vaccinate 25 million doses. So far, this is as of June 20, we reached 20 million doses of shots for our people. From this, 16.2 is the first dose, and 13.8 almost completed their series, because we are also vaccinating them the second dose as well, and the J&J can be also considered as a complete dose. So these are the subnational data. Oromia is one of the biggest region in our country. Amara is the second, SNMP. So accordingly, we are providing the vaccines. Next slide. So this is, to show you the overall utilization. As I mentioned, we distributed 25.4 million doses to different subnationals. From this, I think we have utilized 80% of the doses that was distributed for this campaign. In terms of AFI cases reported, we have received 5,655 AFI cases reported from the subnationals, and some of the serious cases the investigation has been started by our independent authority. Ethiopian Food and Drug Authority has started investigation of serious AFI cases as well. Next slide. In terms of gender and the different age groups, I think we are very fair enough. Male and the females has received almost equal. So 49.2% of females have received this vaccine, and 15.8% are males. So this is, one of the good indications that we have seen in this COVID-19 vaccination. Male and the females have almost equally taking this vaccine. In terms of age, where the majorities are from 18 to 64 years old. Next slide. The other issue overall, from the rollout, from round 1 campaign, round 2 campaign, and the round 3 campaign, so far as a country, Ethiopia vaccinated almost 49.3 million doses of COVID vaccine for our people. From this, 14.5 is first dose, and out of this, 34.6 has completed their vaccination series. We have used majorly the J&J vaccine. In terms of the gender, in total, 48.3 is almost male, and 51.8 48.3 are female and 51.7 are males. So in terms of gender also, we are fair enough providing the vaccine for both genders. Next slide.
Mr. Lakiu, I'm sorry, but I'll have to ask you to accelerate. We have about 3 minutes left, please.
All right, thank you. Next slide. Next slide, please. So as a lesson, what we are learned in the COVID-19 vaccination, intensive communication is very important. Engagement of political leaders and the different stakeholders, like religious leaders and the stakeholders need to be engaged. Integration and the coordination of different sectors like agencies and regulatory authorities are very, very critical. Next slide. Next slide. As a challenge, insecurity is one of the biggest challenge for us. The vaccine instance in urban areas is still a challenge. And we have some local network connectivity problem as well, which is not a global challenge, but we have majorly insecurity and vaccine instance, and the logistic distribution challenge is a very critical challenge where we have a challenge while providing the COVID-19 vaccination rollout in our country. Next slide. So to talk on some of the points on the integration of COVID-19 vaccination with other program and the EPI, specifically EPI, in the third round COVID-19 campaign, we prepared the guideline for this campaign, and as a ministry, we wanted to try by integrating this campaign with routine immunization. So the campaign is not totally completed, but so far we have integrated different activities of routine immunization with the COVID-19 vaccination rollout. To show you some of the major activities, while we are conducting a review meetings of COVID-19, we also review the routine immunization activity together. This is one of the integration. The other issue, when we conduct a supportive supervision for COVID-19 vaccine rollout, we also integrate the routine immunization activity, supportive supervision together. We prepared a checklist for both COVID as well as routine to be supervised at one time. So this is also one of the integrations that we use. Logistic distribution also, the other area that we integrated, because the COVID vaccine logistics and the routine vaccine logistics has been managed by the system simultaneously at one time, and the distributions of at different places will take place accordingly. So this also integrated. Recently in the third round campaign, I will show you the guide. Next slide, please. And this guideline, it has 10 chapters, and on the last chapter, it talks about the integration of the COVID-19 vaccine with the routine and other programs. So we will review it, how we are successful in integration after this campaign. But on the field visits and the supervision, we have seen integration of activities at the subnational levels. Next slide. So some of the activities that has been integrated in the third round of COVID-19 vaccination, routine vaccination also integrated, community mobilization for RI also integrated, TB screening, malaria screening, fistula screening, and the surveillance of VPD, vaccine preventable disease, capacity building activities, and others according to their needs of the subnationals. The COVID-19 third round campaign was integrated with different activities. So this need to be further reviewed, analyzed, and documented for the global community to be shared. So far we are in a campaign. So after a month or 2 months, we will review it, how the integration has taken place in our country, and later on even we will document and share to the global community. But in a field visits and in a supportive supervisions conducted so far in this campaign, these activities has been integrated in different parts of the country. Next slide. So the challenges that we received even with the field visits is one in integration of the COVID-19 and the routine immunization, reporting and the documentation of such activities in a separate modality is quite difficult. So so far at the lower level, the team is doing routine vaccination like reporting through normal DHIS2 platform. There is no separate registration, so it is difficult to document it and report it to the national level. The other issue is it requires also additional human resource or HR to integrate it. The other challenge that we have shown on the field is target difference for the COVID as well as for the routine is also one of the challenge, because for COVID, our policy so far is vaccinating age 12 and above. So there is a target difference, and it is difficult to get children in a COVID vaccination as well. The other critical challenge, it is a budget caps, because integrating such an activity will require additional HR, requires additional resources, printing, documentation, and supervision as well. So these are, the challenges that we have seen so far, and in the future we need to analyze it, review it again, and document it as a lesson, and we will share you to the global level. But these are the efforts as a country that we are doing so far in COVID-19 vaccination, as well as integrating the COVID-19 vaccination and the routine immunization. Next slide. So as a way forward, I have already mentioned it. It needs detailed planning and require further analysis and review and the documentation. And the experiences from different corners need to be scaled up. And the budget mobilization for this task is very important as well. Next. So this is our motto as a nation, as a global: no one is safe until everyone is safe. Vaccine for all. The single case that was reported from China, Wuhan, disturbs the whole world. So this motto comes after that. Actually, no one is safe until everyone is safe. So thank you very much for your attention, and if you have any questions and comments, please welcome. I will be here with you to respond. Thank you.
Thank you so much, Mr. Lakiu. That was very, very rich, and particularly the last couple of slides were really fascinating. I think I could speak for everybody on the call that we would be very interested in the documentation of your experience of this third round campaign. So we have maybe 2 minutes left. So if there's just one question that somebody feels really compelled to ask, please feel free to raise your hand. Yes, Dafrosa, you're the lucky one, the first one up. Please go ahead.
Thank you so much. Thank you, Anna, for the nice presentation. My question lies on the integration. As you put in the challenge, the human resource, and where actually did the integration happen? Is it at the delivery point, or it's in the planning or supply chain? Because as you mentioned in the challenge that the human resource, you have a team of 5. And then if we have to deliver all this, how was it possible while we understand the routine, we have a different target population, and the COVID has also the other target population? I would like to get a lesson learned from there. Thank you.
Please go ahead, Mr. Lakiu.
Thank you very much. Can you hear me?
Yes, we can.
Thank you very much for the question, actually. So in a campaign, you will organize a team to do this activity. So for the COVID-19 campaign, we have 5 individuals with different roles. One will vaccinate, the other will dilute the vaccine, the other will document, the other will arrange, the crowd, and the other will be a mobilizer. So 5 individuals have their own tasks and roles in the team. So when you include, routine immunization, it is quite challenging that we saw on the field because it requires additional experts or professionals to vaccinate children. So that's why we need additional human resource, additional budget for that. So it's not a kind of activity that can be done simultaneously with the COVID, because the targets are too different. Even the mobilization might also take another challenge. So in the coming 2 or 3 weeks later after the campaign, we are going to review it, how the integration is happening on the field. At that moment, we'll see the details, but from the field observation, integrating the COVID vaccination with routine is quite challenging on the field. But for others like logistics, monitoring and supervision activities, reviewing, capacity buildings, all other activities can be integrated. We have done this so far, and we will continue to do this one, because you may not need to integrate all the things, but you need to integrate the activities that can be integrated. So for this, we have been integrating different activities so far, and I will continue to do on that, and I will capitalize on that. But to include the vaccination session integration, it requires additional human resource, budgets, and different planning as well. But we tried it in the third round campaign. From the field visit and the report, we have seen a lot of challenge on that. Thank you.
Great, thank you very much, Mr. Lakiu. So that's really helpful pointers that you just spoke about the systems integration and the continuum of points where you could integrate. And again, I think we're all very much looking forward to your learnings on the ideas of TB screening, malaria, fistula screening, surveillance. So thank you so much for sharing your experience. And we look forward to hearing more after you're done this third round. So we have 2 minutes left. I'm going to hand it over to Santosh to run through some last things and to close. Thank you.
Diana, thank you very much. Just maybe to the slide on what's next. For the next session, we'll be working with the Demand Hub group, and then we have 2 countries. The Ministry of Health will be presenting on the Demand Hub, on the demand promotion, and the RCC engagement. So we'll keep you informed about the presenters and the speakers for the next session. You can see the registration link here, but we'll also send you an email reminder with the details as we come close to the date. A certificate of attendance that's available through the University of Mexico is available. Please also post the link in the chat. Also, you have the link here once you do the post-session survey, which will come as a follow-up email after this session. Then you can get into the details to obtain the certificate of attendance. Next slide, please. All of the training resources will be available in the TechNet 21 website. The link is here, and all of the resources will also come, and the link will be shared with all the participants in the follow-up email that will come through tomorrow. We also have a Telegram group. The link is available on the right-hand side. You also have the QR code. The group is basically to kind of keep it more interactive and just give you an update of the information on the delivery partnership and all of the upcoming sessions. So please feel free to join the Telegram conversation using the QR code and the link. With this, this is the last slide. Thank you all for joining. Thank you to the speakers, and thank you all for listening in today. If you all have any further questions, please feel free to reach out to us. Thank you very much. Have a good day.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you, bye.
Thank you, bye.
Thank you so much, everyone.